Yes, good morning to all. Welcome to another session of Pediatric CME. Today, our guest speaker is Dr. Shamik Shah, consultant nephrologist from American Mission Hospital. He's continuing the sessions on dyselectrolytemia. Last time we had hypo and hyperkalemia, and this time it will be hypo and hypernatremia. Thank you very much for your time, Dr. Shamik. Um, the floor is yours.
Good morning and welcome. Thank you, Dr. Brahmara, for your kind word of introduction. Let's get started with disorders of sodium. So, as we know, the normal serum sodium level is between 136 to 145 millimoles per liter or milliequivalents per liter. And we'll start off by discussing something that we see quite often in clinical practice. And we'll start off with hyponatremia. So hyponatremia, as the definition or the word suggests, it is a low serum sodium below 130 millimoles per liter. So before we get started, let us talk a little bit about the fluid compartments. So we know that there are mainly two fluid compartments, intracellular space and the extracellular space. And the extracellular space is then again divided into two parts, the intravascular space and the interstitial space. So this is basic physiology, and we'll just go through it quickly so that we understand in a clinical context how we are dealing with these disorders. So we know that sodium is the most common ion in the extracellular space, and usually the concentration is about 145 millimoles per liter. Whereas if you look at the intracellular space, then the amount of sodium is really very low. It is just about 12 millimoles per liter. But conversely, when you look at the other electrolyte, the major electrolyte is potassium. And we know that the potassium inside the cells is at a much higher concentration than the sodium. And this is regulated by the sodium potassium pump, which we know is energy dependent, ATP dependent. So we know that intracellularly, the potassium is about 155 millimoles per liter, but extracellularly, it is about 4.5 millimoles per liter. At the same time, we know that water freely moves across the cell membranes, and in places where it cannot move, there are channels called aquaporins, which will help in movement of water across the various compartments, so that the osmolality remains same on all sides. Now, when we are talking about hyponatremia, then there are three clinical scenarios where we will see hyponatremia. So hypervolemic, euvolemic, or hypovolemic hyponatremia. And this will help us in discussion of the various conditions which can cause hyponatremia. Before we jump into the hyponatremia itself, it is important to know what actually is sometimes we see in our clinical practice what we call as false hyponatremia or pseudo-hyponatremia. So what do we mean by a pseudo-hyponatremia or a false hyponatremia? So pseudo-hyponatremia is when our labs tell us that the sodium level is low, but it is actually not low for the patient. And let us understand this clinical condition and in which context we will see this. So the first important cause of pseudohyponatremia is hyperglycemia. We know that when we eat, insulin is secreted from the pancreas, and then this acts on the insulin receptors on the cell, which opens up the glucose transporter and allows the glucose to go inside the cells. Now, in a patient with poorly controlled diabetes, for example, there is a lot of hyperglycemia. And this extra sugar draws the water into the intravascular space because it is an osmotically active substance. So When we look at the vascular space, a lot of water moves from the interstitium into the intravascular space and causes hyponatremia. Here in this, when we measure the serum osmolality will be higher because the glucose, which is an active osmol, increases the osmolality of the fluid. So that is an important cause of pseudohyponatremia. The second important cause is mannitol. We know that mannitol is used mainly in raised intracranial pressure for treatment. Mannitol, we know, does not cross the cell membrane. So it stays in the intravascular compartment or inside the blood cells. And therefore, because it is an osmotically active substance, this will draw water inside the intravascular space. So there is more water compared to sodium inside the intravascular space, but the true sodium which is inside the blood is in the normal range. When we look at the serum osmolality, here also the serum osmolality is higher. So mannitol is a second important cause of pseudohyponatremia. A third important cause of hyponatremia is hyperlipidemia or hyperproteinemia. So this is seen in patients typically with congenital dyslipidemias where they have a very large amount of lipids in their bloods. And why this happens is when we measure the osmolality and the electrolytes, these high levels of lipids or protein, they disrupt the analysis of the electrolytes in the serum. So this results in hyponatremia. Another important post-operative cause which we see is after transurethral resection of prostate, where glycine is used for irrigation. Now, this for bladder irrigation. When glycine is used for bladder irrigation, it also gets absorbed in the intravascular space. And when this gets inside the intravascular space, the glycerol, it also draws water from the interstitium inside the intravascular space. So this also causes pseudohyponatremia. And when we look at the serum osmolality in this condition, we will find that the serum osmolality is normal. So these are some of the important causes of pseudohyponatremia. Now that we have got that out of the way, pseudohyponatremia may have high or normal serum osmolality as we discussed. Then let us get started with the true hyponatremia. True hyponatremia always has a low serum osmolality. So this is important to remember in the clinical context that the serum osmolality will be low in a patient who has true hyponatremia. Now, when we talk about hypervolemic hyponatremia, this is mainly due to the redistribution of water into the extracellular space. So in this, what we will see in this condition, there is a important clinical condition called congestive heart failure. In congestive heart failure, the ability of the heart to pump is reduced. So there is a reduced cardiac output and there is a decreased effective arterial blood volume. This stimulates the release of antidiuretic hormone and stimulates thirst in the body from the hypothalamus. So when there is increased thirst, of course, the patient will drink more water and this will cause hypervolemia. At the same time, there is a release of antidiuretic hormone, which acts on the kidneys. Right? We know that antidiuretic hormone causes water retention from the kidneys. So more water will be kept inside the body, and this will cause hypervolemic hyponatremia. And clinically, we will see that these patients have a raised JVP, they have wet crackles, of course, they complain of dyspnea and cough, and there will be swelling of the lower limbs. But when we look at the osmolality, there will be a low serum osmolality because we are discussing true hyponatremia. So all cases of true hyponatremia will have a low osmolality. Another condition which causes hyponatremia is liver cirrhosis. When the liver is damaged because of chronic liver disease, there is reduced albumin synthesis. Now we know that albumin is an important osmol and it helps in retaining the blood inside the vascular compartment or inside the blood vessels. So when there is reduced albumin, water is not retained in the intravascular space, and this water moves from the blood vessels into the interstitium. And therefore, we get a hypervolemic hyponatremia. Also, in cirrhosis of liver, there is an increased portal hypertension, right? So when we have increased pressure inside the portal vein, the return to the heart is reduced, and the similar mechanism to congestive heart failure. There is a defective arterial volume, there is stimulation of thirst and increased release of ADH, and this causes again hyponatremia in a hypervolemic condition, similar to congestive heart failure. The third important clinical condition which we see is a nephrotic syndrome. In nephrotic syndrome, we know there is an injury to the glomerulus, and therefore there is a leakage of protein in the urine, loss of albumin in the urine. When there is loss of albumin in the urine, of course the albumin in the blood vessels goes down, and again we see the same kind of mechanism that we saw in congestive, in liver failure, that water moves to the interstitium, and we see a hypervolemic hyponatremia. So in this condition, again, if we look at the serum osmolarity will be low. Another important thing to remember is we have to look at the urinary sodium in all these conditions. So in hypervolemic hyponatremia caused by congestive heart failure, liver cirrhosis, and nephrotic syndrome, urinary sodium will be low, because the kidneys are essentially normal, and the kidneys are actively trying to retain the sodium which is being lost. So there will be little sodium which is excreted in the urine. So in all these conditions, the urinary sodium will be low. Now, when we talk about other disease conditions which cause this hypervolemic hyponatremia, chronic renal failure is another important cause. We know that in chronic renal failure, the GFR reduces, and therefore there is an activation of the renin-angiotensin-aldosterone system. So what happens when there is an activation of the renin-angiotensin-aldosterone system? There is a stimulation of the adrenal cortex, which releases aldosterone, and there is a stimulation in the hypothalamus, which causes increased secretion of antidiuretic hormone. Now, both these hormones, we know that they play an important role in sodium and water retention. So there will be increased retention of sodium as well as water. And when there is retention of sodium, water follows it. So obviously, when there is sodium retention, there will be water retention as well. And because there is water retention, there is dilution. So here also we will see that the patient has a hypervolemic hyponatremia. Hypothyroidism is another disease condition in which we will see the same hypervolemic hyponatremia. What happens is in a hypothyroid condition, there will be bradycardia. So there will be decreased cardiac output and reduced effective arterial blood volume. And at the same time, there will be a drop in GFR. So again, because of the mechanisms which we have already discussed, there will be retention of sodium, and there will be retention of water. And when there is a activation of the renin-angiotensin-aldosterone system because of the GFR, again, goes back to the same mechanism which we discussed with chronic kidney disease. So this also will cause a hypervolemic hyponatremia. When we look at the serum osmolality in these conditions, again, the serum osmolality will be low. Here, when we look at the urinary sodium, the urinary sodium will be high, because in chronic kidney disease, the nephrons are not really active. So they are not able to retain the sodium, and this sodium is excreted in the urine. So we will see a high urinary sodium. Now, another important cause is a classification of euvolemic hyponatremia, and an important cause is the syndrome of inappropriate ADH secretion. So we know that antidiuretic hormone is produced in the brain, and this causes the expression of aquaporins. Aquaporins are channels in the distal convoluted tubule which help in reabsorption of water back into the system, back into the circulation. So when there is increased ADH, there will be more aquaporins and more water will be retained. Now, when there is more water retained, obviously there is fluid overload, and so there will be a release of atrial natriuretic peptide and brain natriuretic peptide from the heart. And because of increased water retention, there will be an increase in the glomerular filtration. Now, when there is an increased GFR, obviously the renin-angiotensin-aldosterone system is suppressed. So when we suppress the renin-angiotensin-aldosterone system, what happens is that there will be the negative feedback loop mechanism, and there will be a reduced aldosterone secretion. Now, we know that aldosterone helps in reabsorption of sodium, but by these aldosterone-dependent transporters. So, but when there is less loss of aldosterone, this mechanism is inhibited. So, because of this inhibition, sodium is not reabsorbed, so there will be natriuresis. So when we look at the urinary sodium in this condition, there will be an increase in the urinary sodium levels. And urine osmolality will also be high because of the increased sodium in the urine. Now, over time, when this condition remains for a longer period of time, what happens is there is an adaptation normally happening in the kidneys. What happens is the number of aquaporin channels reduces. So when the number of aquaporin channels reduces, the water reabsorption which happens earlier in ADH does not happen, and so there will be a loss of water as well as sodium in the urine. So this causes diuresis as well as natriuresis, and this is one of the important causes why there is euvolemia, because there is also a diuresis. So we will clinically, if we examine the patient, we will not see any edema in these patients. In this condition also, when we look at the serum osmolarity will be low, because this is again a true hyponatremia. Another condition of euvolemic hyponatremia is what we call beer drinkers potomania. Let's understand how this phenomena works. In people who consume alcohol, there is a increased intake of alcohol. But in the initial stages, these people are not malnourished and they have a normal solute intake. So although there is a water overload, there is a normal solute concentration. So there will be water and solute excretion both in such a condition. But for chronic alcoholics, when the alcohol intake increases substantially more, these people then start to take less nutrition. Because of increased alcohol intake, especially beer, they always have a sense of fullness. So they reduce their food intake, and food intake reduction means there is a reduced protein intake and reduced solute intake in the system. So when there is a reduced protein intake and there is a fluid overload with reduced solute concentration, of course there is water excretion and there is a solute retention with water. So in this condition also, we will see that the patient will have a euvolemic hyponatremia. Now, what about hypovolemic hyponatremia? As the name suggests, these patients are clinically they are dehydrated. And let us look at a few conditions which can cause hypovolemic hyponatremia. One of the important cause of hypovolemic hyponatremia is the use of diuretics, especially thiazide diuretics. So we know that the main mechanism of action of the thiazide diuretics is in the distal convoluted tube. In the distal convoluted tubule, these thiazide diuretics prevent the reabsorption of sodium and chloride. So when sodium and chloride are not being reabsorbed in the distal convoluted tubule, there is inhibition. There obviously there will be more sodium which is available in the collecting duct, and therefore we will have natriuresis. Now thiazides have no effect on aquaporins, so the water which follows sodium closely will also move out with the sodium inside the urine. So these patients will have not only natriuresis, they will have diuresis also. And this is how the main mechanism of action of the diuretic, how it reduces the water in the body. But at the same time, when it reduces the water, it also reduces the sodium in the body. Now, when there is loss of water and sodium, the body tries to recoup this by increasing the aquaporins. But this is only about 10% effective. So ultimately, even though some water is retained by increasing the aquaporin channels, ultimately there will be a loss of sodium and water in the urine, and we will see hypovolemic hyponatremia. And clinically, the patient will feel thirsty. On examination, they will have dry mucous membrane and reduced skin turgor. They will have tachycardia and hypotension, which we see in clinical practice. Another important cause of hypovolemic hyponatremia is, of course, vomiting. In vomiting, we will have water as well as electrolyte loss, right? A lot of hydrogen ions are lost through hydrochloric acid. So water losses cause hypovolemia, and hydrogen ion which is lost through the gut acid causes alkalosis or alkalemia. So the kidney, of course, has to come into action, and it has to excrete more bicarbonate to make this balance. This bicarbonate is excreted as sodium bicarbonate. And when there is excretion of sodium bicarbonate, there will be a normalization of the blood pH. But because of the excretion of the sodium and the bicarbonate, of course, more sodium is excreted, so there will be hyponatremia. And the patient has already lost a lot of volume through the vomiters, so there will be hypovolemic hyponatremia. Another important cause of hypovolemic hyponatremia in clinical practice is diarrhea. We know that there is a loss of fluids, which of course causes hypovolemia. And also from the diarrhea, there is a loss of bicarbonate. And because the bicarbonate is lost in stools, there will be acidosis. Acidosis causes the kidney to come into action and excrete more hydrogen ions to balance out this. So hydrogen ions are excreted as ammonium chloride actually. And this will cause a normalization of the blood pH. So when we see that there is a loss of water from the body, and there is hydrogen ion excreted as ammonium, we will see that the patient will have hypovolemic hyponatremia. A third important cause of hypovolemic hyponatremia is hypoaldosteronism. We know that the adrenal cortex produces the hormone aldosterone, and aldosterone mainly acts on the distal convoluted tubule, on these channels which cause the transport of sodium in exchange for potassium. So when we have a patient with hypoaldosteronism or patient who are taking potassium-sparing diuretics, for example, there will be decreased expression of the sodium-potassium ATPase and the epithelial sodium channels. When these are inhibited, there will be loss of sodium in the urine. So there will be loss of sodium, and at the same time, there will be a loss of water also along with the sodium, because we know that water follows sodium, right? So the water will follow the sodium, and we will see that these patients have, again, hypovolemic hyponatremia. The last important cause of hypovolemic hyponatremia are sweating, burns, and pancreatitis. Right? In sweating, we know that there is a direct loss of water through the sweat glands, and along with this water, the sodium is also lost. While in burns, there is a direct sodium and water loss from the vascular compartment itself, because the blood vessels are exposed to the surroundings. And in pancreatitis, there will be a third spacing. So from the intravascular compartment, sodium and water will move out into the third space. And therefore, when we evaluate these patients, we will find that they have not only hypovolemia, but they also have hyponatremia. So now we have looked at the various causes based on the clinical condition of the patient, whether the patient is hypervolemic, euvolemic, or hypovolemic. What are the clinical presentations of a patient who has hyponatremia? So a clinical presentation, actually, the symptoms depend on the level of sodium. Usually when the sodium is above 120 and the patient and it develops slowly, the patient are usually asymptomatic. But when the sodium goes below 120 millimoles per liter, patients will complain of headache. They will feel lethargy or malaise. They might be having nausea or vomiting. When we evaluate the patient, of course, we have to see whether the patient is hypervolemic, euvolemic, or hypovolemic, according to the clinical condition of the patient. And when we see these symptoms, patients can have cerebral edema, or because of the low sodium, and cerebral edema will cause symptoms because of the water moving in and out of the brain cells or the neuron. The patients typically will have a low sodium, so that water will move inside the neurons, and there will be a swelling of the neurons, and this will result in these symptoms which we described earlier. And more, if this happens more, then the patient will have serious side effects like seizures. They can even become comatose, and patients may have a non-cardiogenic pulmonary edema, because again, when the sodium is low, water moves out of the intravascular compartment into the lung alveoli. Investigation-wise, when we see a patient has hyponatremia, of course, we have to look at the electrolytes, urea and creatinine. At the same time, before we treat the patient, we must do the serum osmolality, the urine osmolality, and the spot urine sodium. If patient has already been treated by either diuretics or by IV saline, then these results will get vitiated. So it is very important to do all these things before we start treatment. And we already discussed that the true hyponatremia will always have a low serum osmolality. Of course, we also need to look at the patient's sugar levels and the triglycerides to rule out pseudo hyponatremia. How will we manage these patients? If the patient is asymptomatic and the serum sodium level is not very dangerously low, usually nothing else is required other than fluid restriction. And when we restrict the fluid and measure the serum osmolality, we will see that sodium level rises and the serum osmolality also gradually improves. However, when the symptoms are more and the patient is more symptomatic, we see patient might require an isotonic saline, which will increase the serum volume and ultimately will suppress the ADH. However, in severely symptomatic patients, or when the sodium level is below 120 ml per minute, quick resuscitation is required, usually in the form of fluids. So rapidly fluid correction is required, and most of the times we require hypertonic saline, which is 3% sodium chloride. When we give hypertonic saline to the patient, there will be an increased amount of sodium in the intravascular space, and this will draw the water from outside the cells and into the intravascular space. And if we do this correctly over slowly over a period of time, then this will lead to correction of the hyponatremia. But please remember that serum sodium should be raised really very slowly. The ideal requirement is that it should be 6 to 8 millimoles in the first 24 hours. Definitely below 12 millimoles or 12 milligrams in the first 24 hours. If we don't do that, and if there is a rapid correction of the serum sodium levels by giving fast hypertonic saline, then we see a very serious side effect called osmotic demyelination syndrome or central pontine myelinolysis. So what happens here, where there is a rapid correction of the sodium, a lot of water moves out of the cells, including the neurons. And when a lot of sodium moves, a lot of water moves out, there will be a shrinkage of the neurons, and this will cause this syndrome of central pontine myelinolysis or osmotic demyelination syndrome, which is characterized by flaccid paralysis, dysarthria, and ultimately can result in a severe morbidity and death. So here, in a nutshell, is how we approach a patient with hyponatremia. We look, when we find that the serum sodium is low, we check the serum osmolality. At the same time, we ask for a urine osmolality and the spot urinary sodium. All these three samples should be taken at the same time. And then based on this algorithm, it is very easy to arrive at a diagnosis of what we are dealing with, and accordingly, we treat this condition. That is all I have for today. I think we will stop now. It's already been 35 minutes, and I don't want to bore or tire people with too much electrolyte disturbances. So I'll stop here, and if there are any other questions, I'm happy to answer them. Okay, if there are no questions, then I think we'll close this meeting. Thank you very much.